Okay, good afternoon. My name is Tim Estelo. I'm an occupational therapist from the Children's Hospital of Philadelphia. I'd like to thank Stanford University for giving me the opportunity to speak to you today on occupational therapy, best practices for pediatric sitters. I'd like to thank Tina and Dr. McCurry for giving a great lead-in talk and so nicely covering the phenotype through the lifespan of this patient population. As we know, it's an ever-changing population. I'd also like to thank my co-presenter, Julie, and my coworker Kim for the excellent talks they gave yesterday. They spent a good deal of time covering some important issues like aquatic therapy and also seating and positioning. So I will touch on those briefly during my talk today, but I'll use the time to concentrate on some other areas a little more. And then Julie, again, will reinforce some of the seating and positioning concepts as well. We thought we were going to be short on time. Luckily, Dr. Day let me know that there's no talks following this, and nobody has plans for the Friday afternoon, so I can feel free to hijack you guys and keep you all day long. But in all seriousness, I want to keep this as interactive as possible. I realize that's hard to do through a virtual format, but if you can use the Q&A portion on HOVA, if you have any questions, feel free to ask them during the presentation. If there's things you see on the slide you want more detail on, if you want me to go back a slide and discuss something in more depth, please let me know and I'll do my best to accommodate that. So as yesterday, we're going to review the standard of care guidelines in SMA. Okay. The way I'm going to do this today is I'm really going to focus on the impairments, the evaluation of these impairments, and what we do from an interventional standpoint. And I'm going to try to illustrate this in two ways. One, our classical case of an SMA sitter, as well as our new treatment era based. As we know, if somebody can mute, I'm getting a lot of background noise. As we know, as occupational therapists, our primary goal is to maximize the independence and efficiency and activities of daily living for our patients. Everybody's very familiar with the methods that we use to do this. You can see them bullet pointed below. The idea here is that there's a hierarchy in which interventions we use, which ones are appropriate for which type of phenotype in SMA, and the evaluations that we use. So what I'm hoping to do today is kind of show you how we move these interventions or these areas kind of up and down the hierarchy to meet the needs of our patients. This is a quick video I want to show you. I'm going to spend a lot of time today talking on, specific data, details, movement patterns, type of muscle contractions, things that are kind of very, micro level things. And I think, I love to have a macro view at times, and we are limited in our discussion today. So I do want to take it back to the kind of top down level and show ultimately what we're working for. Typically we see these patients in a hospital setting or maybe in a community setting, so we don't get to see them in their everyday life. And some of the small things that we work towards, we don't always get to see how that ends up benefiting or helping them in the community. So here's my buddy Pete. He's on the right-hand side. He's here with one of his good friends. They're about to have some fun, and I'll let you see the video. Unfortunately, the sound's not working well. So his friend's giving you a tour of the wheelchair. They're going to show one of the best uses of old DME equipment I've ever seen. So there's his old tumble form chair. He's safety conscious. He has his helmet on so he doesn't get hurt. Pete's in the wheelchair, and I'm sure you can see where this is going to go. He lets out a few expletives here as he starts to spin around and lose control. And they're having a good old time. So I think, we really need to view our patients as, as kids or young adults or whatever the age is, and really think of them in the context beyond where we see them, and focus on, what can we offer them in the clinic setting? What can we do to really impact and change their life? So in the case for someone like Pete, when you're looking at hand function, the amount of movement that he has in his thumb or his index finger, or a little bit of movement in the wrist might not be the most impressive amount of movement, but, had he lost that movement or had he not had the ability to manually control his wheelchair, that would severely impact his ability at the participation level in the community as a friend, okay? So I just wanted to direct some attention there. I'm not going to speak too long on signs and symptoms. That was covered in the talk this morning. I'm sure you're all very familiar, but I do want to illustrate some data from our International SMA Consortium. We did an upper extremity study on children with SMA type 2. And I just really want to point out the level of, when you hear about muscle weakness and you see some of the videos, I think it comes through, but when you see the numbers, it's quite staggering. And if you look here, these are myometry values that we took from roughly 50 patients with, like I said, SMA type 2, so all sitters. And these are large prime mover muscle groups, so shoulder abductors, elbow flexion, elbow extension. And if you look here, these are the mean values for the group. So many of these values are a pound or less. So when you look, and even if we look at the median values, more than half of our kids can execute or are unable to execute even a pound or more than a pound of muscle force at the majority of their upper extremity groups, with the exception of the elbow flexors, which are the strongest, but still we're only looking at 2 pounds. So 2 pounds of force is not a lot of weight. So the weakness here is a big issue. Again, these are mostly historical cases or kids who are newly treated. You have to be generally at least 3 or 4 to do myometry. So the kids who are now benefiting in the early on stages of the disease, we don't yet have data on where their strength is in this sitting phenotype. Additionally, contractures, right? Part of your evaluation, you're really going to want to focus on contractures. Not as important in the ambulatory group, but in this sitting group, you can see that it's very common to have proximal, mid-level at the elbow, but also distal, some forearm contractures. Contrary to what you see proximally, there's actually quite a good deal of hypermobility in the distal joints of the wrist and the hands. When you combine that hypermobility with the weakness that's there, it can really cause functional limitations. So how are we going to structure our evaluation? You'll see throughout the slides for reference this table on the left-hand side that shows the rank and orders these from a list of more to less important either evaluations or interventions as we go through. This wasn't a specific OT run thing. This was more physio or PT based. But as you look through, you will see things that cross over into discipline, and it also give you an idea to understand how these things shift from group to group, from the non-sitters, the sitters, and the ambulators. So, to get the most bang for your buck in terms of your evaluation, you really want to start with an SMA specific outcome measure, the ROLM or the attend. This is going to give you the opportunity to see how these children can move in space, how they can reach, what their functional workspace is, what sort of fine motor skills they have. And it's a great measure, which I'll show you a little bit more on the next page, but it also serves as a screener where then you can then decide what you need to look further into from a range of motion standpoint, or what you think they may be capable of from an ADL standpoint. Postural control, right? This is the sitter group. Just because you can sit doesn't mean you have great postural control. So you're going to want to evaluate their head control, trunk control. Are they able to sit up, but they're not able to reach with the arm because they don't have sufficient strength to maintain them, so they're limited? Do they need to have a single arm prop, which then limits their ability to use both hands to manipulate and play and interact with toys? So postural control is an important thing in this population. Once you get through that, the use of norm referenced outcome measures is important, and I'll show you some of those and talk about how they can be helpful at monitoring progress in this population. On the top left here, you'll see the information for the ROLMs. You can certainly read more about that outside of here. I won't speak to that. It was also covered last year in depth, so you can access that through the Stanford site as well. But the ROLM, again, excellent upper extremity outcome measure. On the left here, you can see that the ROLM is able to differentiate between different phenotypes. So you have our SMA type 2 group, our SMA type 3 who are non-ambulant, and then also the ambulant SMA type 3. So it does a good job at differentiating between the different phenotypes. But also, if you look at these other two, and again, this is from our SMA type 2 cohort, there's quite a wide range of variability on the right here, even within the same type, okay? And even across the age span. So it gives you a good opportunity to see how patients are performing, and then also, as Tina showed, you can monitor change in response to treatment over time. Of particular interest with the ROLM is, if you have experience with this, then you'll see The roll was a scale that goes up to 37 points. The large predominance of the points that can potentially be earned come from proximal, from shoulder reaching items. There's less items that look at the mid and lower level scores. However, for this sitting population, the majority of points that they accumulate are at the mid and the lower levels. And this will come into play later in a few slides where I show you why that's important. Great assessment that we love using at CHOP. It's also used elsewhere. It's called the box and blocks assessment. This allows you to look at several things. The way it was designed was for a 1 minute all-out sprint. How many blocks you can pick up in your hand, transfer across and drop into the other side of the bucket. Bart Bartels has done some good work with his group looking at a sub-maximal shuttle test to measure fatigue. At CHOP, we do kind of a hybrid model where we have them go all out 3 minute sprint, as many as they can move in 3 minutes. That way we can look at the 1 minute normative reference values to see their performance. And then we can also observe if there's fatigue over time. We haven't looked formally yet, but from informally looking and anecdotal experience and looking at our charts, it appears that this is a good measure to capture change in our patients with treatment. The young lady here is a roughly 23-year-old SMA type 2 sitter. We followed her, well, I don't want to tell how long I followed her for because it'll give my age away, but followed her for many, many years. And 2, 3, 4 different occurrences over time, was unable to transfer a single block. She's received nusinersen and had treatment for several years now. You'll see it here in the video. She's now able to do it. The value in this assessment is that you can also capture some of the distal grasp function. A lot of our sitters might not have excellent fine motor skills. Some of the non-sitters who are in the new treatment area merging to becoming sitters as they start to develop hand function. This will allow you to capture some of the grasp. You can notice that the predominance of her movement comes from the elbow. So she flexes the elbow up to get the elevation she needs. She then uses her trunk to generate some momentum and get the arm across. There's no movement occurring proximally at the shoulder. And when I show you tomorrow when we do the ambulators, you'll get to see how that compares versus an ambulatory patient. So active range of motion is a measure of strength. We spent a lot of time on the slide I showed you previously measuring myometry and the biceps, the triceps, the shoulder, and it really doesn't do a good job in this sitter population at this time at differentiating between the patients. I showed you the spread of data on the roll and how there's a nice distribution of performance on the roll, but there's a big floor effect with the myometry and everybody kind of hovers around that 1 pound or less. I'm starting to think that using active range of motion as a surrogate measure of strength, which is part of the construct that's built into the ATEND, it is going to be probably a better way to look at strength in this group. And I want to spend some time speaking about this because this leads to not only your evaluation piece, but also how you think about planning your intervention and then how you intervene. So when we're thinking about range of motion with these kids, we know they have significant weakness. We really need to think about how they're moving, right? How do we have them positioned? Are they moving against gravity? Is it in a gravity eliminated plane? Have they reduced gravity? What's their muscle length yet? So you may have kids that if you have the arm fully extended at the elbow and you're asking them to flex the arm to look at their active movement, they're unable to initiate that contraction because you have that bicep that's completely over lengthened and it's in its weakest position, right? So what can you do? Then you can take the arm, you can partially bend it, right? Put them at mid-range where they have more of a biomechanical advantage and stronger and see if they can initiate from there, right? You want to think about how are the muscles working concentrically, right? When they shorten, isometrically, when they don't change length and you just hold the joint in place, and also eccentrically, the lowering movement. If I was to see a patient in clinic, or if I was to pick a patient up for treatment and another therapist evaluated, and I looked at the eval, and I wanted to know what kind of elbow extension they had, and I looked, and the notation was no anti-gravity elbow extension. Okay, so that's a little bit of information, but it's not really helpful for me. All it does is tell me what they're not able to do. It doesn't give me an idea of what they can do. If they took the next step and they said they had full gravity eliminated elbow extension, okay, now I understand how they can move in a gravity eliminated plane. I understand how they move against gravity, and it's more helpful, but I'm still missing something in between. What's most helpful is to really look and see, what can they do isometrically? Can you position them at 90 degrees against gravity? Can they maintain that? Can they maintain it for a second and then have graded eccentric control? If you And then also concentrically, how close to end range elbow extension do I need to place them against gravity for them to be able to initiate and conclude the movement? So, if the patient's in today and I place them at 150 degrees, right, of elbow extension, and they can work through that last 30 degrees to end range, now I have a number that I can quantify and I can follow over time. And I can look as that range expands over time, as opposed to if the only data point I had was they have no elbow extension, it's going to be a long time before I can see them get active extension against gravity from that start point of full elbow flexion to starting to move up from there. So why is strength and contractures important in the sitting population? So it's important for a couple of reasons. One, and it's logical, right? The stronger you are, it leads to think you may be more functional. So these 4 graphs here on the x-axis show the muscle force. On the y-axis show the score on the ROM. All right, there's two things you see here. As patients generally get stronger, there's an increase in their performance on the ROM, right? But also interestingly, if you look at the beginning here, for all 4 of these, even the patients with 0 or just above 0, so unmeasurable force thermometry, there's still quite a range, and some of them perform quite well on their own. So if you think about it, when we do myometry, this is a stabilized, isolated movement where they're unable to use any compensatory strategies. So if you stick to myometry alone and you don't observe the patient, you don't get the full picture. So when you do an assessment like the ROM and you get to see how they move in space, how they use their trunk, how they can initiate momentum, that really gives you a good idea of how they function in the real world. The prime mover and the goal in undertaking this study was to figure out how we can best now address intervention modalities in this new treatment area. We have patients who are evolving, right? We have patients getting stronger. There's lots of stuff we can do. We have limited time to evaluate, and we have even limited time to intervene. Even if you have an hour-long therapy session, what are you going to work on? Head control, postural control, strengthening, stretching, ADL, self-care. I mean, the list is endless. So the goal here, this is very preliminary data that we haven't finalized yet, but we wanted to look and we plugged in all of the measures of strength and all the joint range of motion, passive range of motion, and we wanted to see which ones were the best predictors of the variability and function on the ROM for the sitting group. So if you look, you can see wrist extensions. This is passive wrist extension. Patients that have a contracture at the wrist perform worse on the ROM. And this makes sense because if you think about it, if you're unable to extend and elevate your wrist in space, you're going to have to then either flex your elbow or flex or abduct your shoulder to elevate that arm to get it in place to function. And we know the proximal weakness exists. It's hard to do that. So that's a big limiting factor. And then as you look at the other independent variables, wrist extension strength, elbow flexion, elbow extension strength. So we talked about these mid-level items on the ROM or where the kids score most of the points. So if you can improve the strength at that elbow joint, theoretically, you can improve function on the ROM. Now, this requires longitudinal study and looking at data over time, which we have some, but it's limited at this point. But I think just to get the starting point of thinking, where do I want to focus my strength on and my session on, and what muscle groups may have more of a priority than the other groups. So what do we do? All right. So as therapists, we know we can remediate. We can try to improve muscle length. We can try to improve strength. We can work on balance. Historically, these weren't things we did with this population. Like Tina mentioned in her talk earlier, it was really a reactive approach. So now we're in this proactive and this anticipatory area where we want to see what we can remediate and what we can work on. Additionally, there's this, which was our previous approach, adaptive compensatory method, where we didn't have any anticipation of improving strength past a certain point. We didn't anticipate they were going to necessarily gain skills past a certain point. So we had to find a way to bridge that gap. So I think right now the answer is both. My preference is to give whatever adaptive equipment, compensatory techniques, assistive devices, give whatever the child or the adult needs to get them functioning to their maximum capacity immediately, and then identify where you have realistic expectations that you can actually improve something from a remediation approach, because we want to make sure that we're using their time purposefully and that it's valuable and that they're working on things that are actually attainable. Otherwise, we're going to lose the patient buy-in. So first area of intervention, positioning. Positioning extremely important in this population because of the sometimes weak trunk initially, and then as they go older, they get stronger. So stable base, very important. TLSOs as well as other devices appropriate. Julie spoke quite a bit about this yesterday, and will speak as well today, so I won't hang too long here. Contracture prevention. So we know that the shoulder and the elbow and the forearm are at risk. We know that the mean across our group is missing about 15 degrees passive range of motion in all of those. And any increase in muscle tightness and limitation is a resistance to active movement. So it's very good when you screen your patients, if you identify this, that you establish them early on with a stretching program. If the tightness progresses, they have a contracture, they're getting increased tightness, you can get a little more involved and begin splinting. Night splinting is the preferred approach. The only time I really advocate for a splint on the child during the day is two things. One is if it's going to improve their function. So sometimes we'll use a little dorsal wrist cock-up splint for kids that have wrist drop or very weak wrist extensors so that they can power their grasp so they can hold on better. Or two, if it's a kid who's very weak and, like I said, just has wrist drop and can't move at all, and you're trying to prevent that position of deformity. There was a question yesterday about kinesio tape and when you would use that. I think kinesio tape can be a great tool in this population. Ideally, you want someone that has anti-gravity movement. So I'll start from the top and work my way down. So if you have a patient that has anti-gravity movement, but has a hard time sustaining it or fatigues over time with repeated wrist movements, this is a good candidate, right? They can move against gravity. This is going to be an active assist. It's going to help them. If you have a patient, excuse me, if you have a patient that has difficulty initiating wrist extension, right? But you position them at neutral or somewhere, and then they can get some more movement. Then, it's possible that by applying the tape and positioning the tape under tension to extension, that you can have them rest at a more neutral or close to neutral position that allows them to actively fire. If somebody has no anti-gravity movement, very limited gravity, decreased movement, it's not really at that time going to be worth your while to try that intervention. You want to kind of save it until they show a little more. Two other areas that, again, I'm not going to speak on today because they were covered in depth yesterday, but phenomenal for this sitting population in terms of strength everywhere, head control, posture control, limb strength, is the aquatic therapy setting. Hippotherapy, very good for head and postural control. And then, of course, community-based adapted sports and the arts. So how are we going to strengthen? So you might think somebody has 1 pound or half a pound of measurable force, they can't strengthen. Well, not so. And this way I'll go the bottom up. So if you think of our most weak patients, I talk about muscle length and position often, that they're often stuck in positions where, whether it's the shoulder is all the way extended, or the elbow is extended, or the wrist is dropped, they're starting at positions where they're at a disadvantage. So by using devices that either give active assistance, like a mobile arm support, whether it's powered or rubber band driven or some other driven, that lessens the weight of the arm, decreases the impact of gravity, allows them to use the muscles and muscle strength that they have to move through the pattern, is a good start. Slings and springs, I'll show you some slides on that. I know you saw some yesterday as well. Gravity eliminated, right? So we can reduce friction. We could put an arm skate on the table. We could put some parchment paper, around the hand, and put some rubber bands to keep it on to decrease the friction so the child can move. And then as you progress up and they progress in strength, you can use place and hold exercises where you position the hand in space or the arm in space, and you work on isometric holds or eccentric control. So you can take this graded approach to strengthening over time for the patient. And the focus when you're talking with the parents is you always want to show the steps. This is where he or she is now. This is the next step in their active movement. Once we get here, this is what's going to follow that. So you want to kind of pave the way of how they're moving to improving their strength and how that's going to help them function. Right? Preferential selection of muscle groups. So we know that the triceps are by far the weakest upper limb muscle group, much weaker than their antagonist, the biceps. So it's very common that you have a child where you may be able to work with dumbbells, right, or cuff weights for the biceps, but you're really going to have to get in this gravity eliminated plane for triceps. So don't get locked into one method or one movement pattern for all the muscle groups. You really have to look at and think in terms of intervention on where their strengths lie. So we'll move into our case studies now. The first one is Henry. Henry's a 3-year-old male, SMA type 2. Unfortunately, he's no longer followed at CHOP. He gets followed close at home. So you'll see my pictures of video cut off at a younger age, but he's in this new treatment area. So he's going to be a different phenotype, and you'll see a very different presentation from the other gentleman I'll show you. 5 months old, the parents noted he stopped kicking his legs as often, diagnosed at 9 months, and by a year was on Spinraza and received therapies. At his evaluation, early on, we noticed he already had some forearm contractures that limited his supination. You can see he had very limited shoulder flexion. He was asymmetric. He had much more movement on the right than the left. So again, asymmetry, fairly common. We looked at active movement in this group as well. But distally at the elbow and further down, he was good. Here's my friend Henry reaching for the ball. I had to shorten the video for time. Just with a little bit of support here from the tumble form there, he's able to sit up and do some reaching. Later on in the video clip, he placed the ball a little bit further laterally. He deviates about 10 to 15 to get the midline, and then he flops over. So for him, when we're working on reaching, we really want him supported well here. You can see in the video, he flexes the elbow nicely, he can extend the wrist nicely, but to really lift that arm in space is a challenge. And he really has a hard time getting that arm away from his body. So that limited reach, his limited mobility is going to impact his ability from a participation level to explore his environment, to play, to reach for toys, to assist with his self-care. So he would try to push his arms through his sleeves as he got older. He had difficulty with it. He would finger feed, but he had a hard time trying to pick up anything that was heavy or weighted. They had less fluid in the sippy cup. So what are we going to do for Henry? So we wanted to work on postural control. We wanted to work on increasing his range of motion, and we wanted to improve that passive supination. So hopefully he could gain some active supination as well and not have long-standing contracture to limit his function. One of the best places for the infants to play is in supine. The kids are lying down. They're getting very good support from the floor. They don't have to worry about head postural control. Also provides scapular stabilization. For him, this gives him two things. One, the ability to move his arms in abduction, his shoulders in abduction in a gravity eliminated plane, gives him the ability to flex his shoulders in a gravity reduced plane, but also gives him the opportunity to work against gravity and continue to develop the endurance and the strength in the tricep muscles. As he got a little bit older, as he got a little bit stronger, you can see here he's able to sit up more on his own. We use the slings and springs. This allows to put the arm in a position where he doesn't have to work as hard to maintain that position with the deltoids. He can now use his pecs and his posterior delts to horizontally AB and adduct the arm. He can play. So not only is this important from a therapy standpoint, but now we've given him a leisure activity that he can sit, maintain the arms in space for a long period of time, and engage in activity, which is going to be therapeutic for him. Here's two pictures of him sitting up. You can see the kyphotic posture. Sometimes kids who are able to sit have a little bit of that low tone, respond well to tactile facilitation or vibratory facilitation, right? Or a little cueing, anything you do can do quite well with some dynamic movement orthosis garments. So here's a picture of him there. Additionally, the aquatic environment, as well as your typical physio ball, which I know Kim showed a lot of video of a patient working on the big physio ball, is the way to really address working on that head and trunk control. And finally, for him, we did some passive range of motion that the family did every day. He was severely limited in shoulder flexion, so we wanted to make sure that passively he was moved through the full range, as well as the supination stretch. So we don't give stretches for every joint. The ones that aren't at risk don't need to be stretched. We want to make sure that he's active, that their time consumed with their son is in activities that are going to be beneficial and also fun, and not kind of burdened down with stretching the whole body.
Hey, Tim, right. You have about 2 minutes.
Okay. So he had pretty much standard baby equipment and the DMO. Next case study is an older patient, more historic case. This is a 12-year-old, okay? Was diagnosed at 10 months old, lost the ability to crawl, started Spinraza at 9 years old. So when you heard I think Dr. Finkel speak this morning about, right, all that motor neuron loss over time, so you're gonna have a different picture here. So you can see in his evaluation, very, very different. Only had trace movement at the shoulders, okay? fairly good movement at the elbows for flexion, but very limited elbow extension. So this is a very different picture than the little guy we just saw who could actually flex and move the shoulders against gravity. So for him, this is going to severely limit his ability to reach away from his body. His score on the Rome here, and the max score on the Rome is a 37. He only got a 9 because he's unable to complete any of the proximal items, any of the reaching items. 9-hole peg test we did is a good measure to look at hand function. Again, 14 standard deviations below the age expected mean, and he was unable to do the box and blocks. So you can see from an activity level, his limitations in movement severely limit him. From a participation standpoint, he's able to flex the elbow to bring the hand up towards the mouth, but he doesn't have enough movement at the shoulder to then elevate the hand further in space to brush his teeth, wash his face, do his hair. This impacted him in school in his ability to use the tablet. So our immediate goal with him was we got him a mobile arm support. We wanted to give him as much function with an assistive device as soon as possible so that he could function. Additionally, we wanted to work in therapy to try to expand that reach. So we don't always have to make huge improvements in terms of the quantity of range of motion that we have to get large degrees of function. So if we use the slings and springs and we support his arm and we allow him to strengthen those pecs and those delts and those rhomboids enough so that he can get another 10 or 15 degrees of movement in each direction, that's a difference between him not being able to use any of his iPad or being able to access or his tablet, the whole right half of the screen. Same thing down low, you'll see here. He's playing the boxing game. So again, in addition to these being good therapy options, this is a good way to give a child that has very limited motor skills a chance to have some leisure activity. So he can play with his siblings at home on his Nintendo Wii. He can play the boxing game. You can really see he gets excellent repetition here at that elbow. You can see he's punching. He's working on protraction, lots of elbow flexion, elbow extension. So these are movements that he wouldn't typically be able to do without this support. Okay, I'd like to thank mostly the patients and families for allowing us to share their stories. Nancy Green was a doctoral student that helped me with retrospective SMA data collection, some of which I shared today. I'd like to thank Stanford for giving the opportunity. And then finally, I'd like to thank my family because without their support, this wouldn't be possible. Resources. So if there's any questions, I'm happy to address those now, or we can wait till after Julie's talk. I'm open for either.
Tim, I didn't see any questions come through.
Okay, so I'll stop sharing now and then.
Okay, and then I'll go find mine. Okay. Can you hear me all right? So my name's Julie Muccini. I'm the occupational therapist at Stanford Rehab. I'm in the outpatient neuro rehab clinic, and I'm the only sole occupational therapist working in the neuromuscular clinic. And I feel extremely fortunate to be able to work with Dr. Day and Sally and Tina on a regular basis. I have no financial disclosures, no financial relationships with any of the vendors or products discussed in this presentation. And I just want to mention briefly from listening to this morning, I really was struck by, the case number 4 for adults that Dr. Tabor opened with. Our role when we work with the adults, our patients, non-ambulating sitters, is really helping to identify their priorities. These patients don't really want to come to rehab anymore. They have worked very hard for a very long time in the pediatric environment. And when they come to me and I meet them in their 20s and 30s, they're showing up with their hired caregivers, and they come once in a while. They're not, we don't see them as often. And so it's really important when we do work with them to immediately address their needs for activities of daily living or IADLs, range of motion, the splinting aspects, revise their durable medical equipment and their complex rehab technology and their transportation. So we know the range of abilities of our non-ambulating sitters, and so that's what I hope to address today. Just to also mention, our patients are extremely smart. I am so fortunate and blessed to help these individuals access their education, access their work environment. They're getting graduate degrees at the best universities. They're working in Silicon Valley. They're accessing the arts and humanities. They're consultants to tech companies. It's just really a privilege to work with this patient population. My patients generally require assist with meal preparation, but they are able to do their own self-feeding. In my experience with my adults, they can be modified independent with their upper body dressing, but generally, max assist with their lower body dressing. They can be modified independent for toileting, modified independent to max assist for bathing activities. And again, it depends on the environment. And they are for sure using powered mobility to access home and community. And they are employed or accessing school and using their computers for access. And some are driving adapted vehicles. Oops. Oh. So the evaluation, as we know as occupational therapists, we're assessing the level of assist, passive range of motion, the active range of motion, ability to access their home and their community. Like I said, I'm fortunate to work with Sally and Tina, and they are the ones who will complete the revised upper limb module for SMA or the SMA functional rating scale and all the other scales. So I have a tendency to dive right into the details of durable medical equipment and complex rehab technology. I apologize for doing this. The goals are, let me just move this over here. I'm just going to move the video, sorry. Our goals in treatment are really to continue their ability to access their environment and access school. And just also, like I said, my adults arrive to visits with caregivers, not their parents. And so for us, it's really ensuring that their caregivers understand exactly what to do, how to do. They have rotating caregivers, and it's really important that everyone's on the same page. And obviously access to the technology, which is ever changing. I mentioned yesterday, and for those who heard yesterday, this is a little bit of a repeat, but I do write some of the durable medical equipment prescriptions, and then our physician team will sign off. We work together very well. I don't know why it's not advancing. There we go. One of the areas of concern are splinting. So some of my folks come in, they haven't worn their splints for a very long time. And so we're trying to identify if a splinting now at this point would be helpful for nighttime. If so, being mindful of monitoring for pressure ulcers. Can it be off the shelf? Does it have to be a custom thermoplast? We're fortunate at Stanford, we have a wonderful access to a certified hand therapy clinic. And so I will refer my patients to them just to revise some of their resting hand splints, protect their elbow joints. We dabble or considered low load dynamic tension adjustable splints, but that's not as well received. Just how important it is that sleep promotes your sense of wellness and allows you to heal, and just helps with your attention and concentration. So it's really important that our patients are sleeping well as adults, that their caregivers are sleeping, because they're not having to assist position changes every few hours. So for everyone to be getting sleep, that's really, really important. And so for some of my patients, they are doing just fine with a semi or fully electric hospital bed. And some really go all out and will work on a type of lateral rotation mattresses and or pro bed, which facilitates rotation, as I mentioned yesterday. And some of my patients are just fine with a sleep store bed with a sleep number or some type of Comfortpedic. And then in the lowest tech, they're using a mattress genie, which is just an inflatable wedge, which you utilize with a remote, and you can facilitate the head change of head of bed or foot of bed. And again, that movement is really, really important. And I did mention this yesterday, I'm going to mention again today for my pediatric colleagues, how important it is to be sure that your patients are teed up with everything they possibly need before they enter the adult side. And it was mentioned earlier in the sessions, in the panel discussions, that it's really difficult when you're on the adult side for insurance to cover complex rehab technology or appropriate hospital beds. And so if you could be sure that they have all of these things before they come to the adult side, that's always incredibly helpful. Standard durable medical equipment for bathing or toileting. My adults are like, oh, it's the same equipment I've had since I've been, on the pediatric side. And of course, by the time I see them, it's broken, it's being held together by duct tape, it's rusting. So, some folks, some of my patients are very able to utilize a drop arm commode for their toileting activities with those lateral transfers. And some have caregivers that will facilitate their showering. And so we're specifying some really nice equipment, those custom rolling commode shower chair systems to access their toilet and their shower, their tub showers. Some are still capable of using the transfer tub slider bench. And it's really important that you, especially now at telehealth, I have the advantage of doing these virtual home evals. So people take me through their homes, and it's really been a nice change to be able to see that and make these really effective recommendations for equipment given what they have in their home environments. And when I do work with these adults, we talk about home modifications. Of course, we do always mention that the seamless roll-in shower stall is best. You always want people accessing their showering environments, and that's super important. Our folks, my patients are quite dependent, not all, some are dependent for their transfers in this population. And so, whether they're using the Hoyer or the MoLift or the Lyco, I just want to mention that this shape, this is that high back split leg sling. And some patients are still using those other types of slings, which are more like the shape of a rectangle because they were smaller, but now they're adults and they're bigger. And those full-size slings are not appropriate anymore when they show up to my clinic, and I'm seeing that they've been sitting on their sling all day and that's their regular practice. It's really disturbing because it's best practice to have these slings removed. So this one you put on like a shawl, you hook the tails under the legs, and then that's how you can transfer them. And again, they're not pediatrics anymore, they're adults, and they really should not be sitting on these slings. There are lots of really wonderful overhead lift systems. And then as I mentioned yesterday, the Voyager portable ceiling lift is something that you can break down. It has a travel bag, and you could take it with you if you're going to go on a nice vacation and you want to ensure your safety with transfers with you and your caregiver. The mobility has a huge range. So some of my non-ambulating sitter patients with that situation, they are in their group 3 or group 2 power chairs. Some I'm speccing ultra lightweight manual wheelchairs with power assist wheels. And of course, that is also complex rehab technology. A lightweight scooter is durable medical equipment. And so some folks really are able to manage a lightweight scooter. And so you have to look at what the patient wants. How are they accessing their adaptive vehicle? How are they accessing a campus or their home or a work environment? What tool is best for them, and what's their tolerance, to last the course of an entire day? In the complex rehab technology, in yesterday's group, the non-sitters, I spoke a lot about the custom seating. So of course, a group 3 power chair is a custom chair, but you don't necessarily have to have custom seat cushions or custom seat backs. You can do off the shelf that's measured to the person, but it's not like a molded system. And of course, the power seat functions, if they're choosing to be in their group 3, will always be the tilt, recline, power center mount legs. Even with contractures, it's still helpful to have that range of motion facilitated by the power center mount. Of course, power seat elevators are not covered by insurance on the adult side, nor are the sit to stand not covered. I do have some folks who work at very prestigious companies in Silicon Valley, and their private insurance can be persuaded to cover some of these more expensive power seat functions features, but it's a struggle. You really have to justify. My documents are like 8 pages long. And like I said, back to the cushioning, you want to, make sure you have hip and thigh guides with adjustable, removable hardware. The seat backs mildly contoured with trunk lateral guides, because we're not molding them, but we still want to provide that postural support. And the armrests don't have to be custom. Like in my yesterday with the patients who are non-sitters, that mostly custom. But my other patients, it does not. It can just be the standard armrest. And then you really make a decision on the type of fabric, whether they want it smooth or fabric. And the controls are generally a standard joystick with button actuators for managing all the power seat functions, and joystick for drive, not necessarily alternate controls, unless they can't reach the power on off, or if they cannot reach the mode, and then you might want to add a micro light switch. Just again, custom rehab technology does include the ultra lightweight wheelchairs, which are the K0005s with power assist. So that is a custom chair, and generally I will spec a rigid backrest, not tension adjustable. And I'll show a picture. The power assist is things like Smart Drive or power assist wheels. And then for folks that are able to drive a scooter, that is durable medical equipment. And those are lightweight powered mobility scooters with a rotating seat. It is not customizable. And again, considered just plain old DME. So these are examples of some of the custom ultra lightweight manual chairs. And these are examples of the kinds of power assist. So down here, Smart Drive, you can see the price tag's about $7,600. So I will do a full-on eval and a letter of medical necessity. The eMotion and the eMotion power assist wheels, that's the price tag for just adding these wheels. And so it does require a trip to the physician, and they have to justify it in their note. I have to justify it. We work with our assistive technology professionals to make these things happen. And it's a really nice way to access a vehicle. It's easier than transporting a 350-pound Group 3 power wheelchair. These are Group 1 and Group 2 power chairs. And again, it depends on what my patient wants. These type of lightweight wheelchairs, just so you know, are really not covered by insurance. They don't have, they're not coded. And so that makes it challenging. Medicare for my adults will pay for the monthly rental for some of these Group 2 power chairs. Again, not custom. These are just standard chairs with a joystick control. Some of the price tags are popping up here for some of these scooters. And then again, they do have Group 2 chairs that now have power seat elevation, which is a wonderful way to access community and just gauge. And again, proximal weakness, some distal strength. So if you have height, you can still press some buttons, you can still access your home environment. And obviously adults living alone and with caregivers popping in and out, this is incredibly important. These are for the Group 3 power wheelchairs, power seating. So what I consider best practice is, of course, having this power seat elevator. And depends on your vendor, depends on the model chair you get. That price tag is in addition to like $1,500 to $2,600. And again, it depends on your vendor. These are the functions that sit to stand. That's anterior tilt. That's not covered. Speed package. Some of my patients really like to crank on the speed because they have places to go, people to see, and so they want as fast as possible, and not generally covered by insurance. They don't consider that medically necessary. I try and justify it, of course, and then the power seat elevator and the standing. I work as hard as I can to justify everything, but insurance has their ideas.
Julie, you have another minute or so.
Okay, I'm nearly done. So the durable medical equipment recommendations, Tim already spoke of the mobile arm support, so I'm not going to get into that, but of course the benefits are accessing functional environments. I do want to say our role working with our adults is access higher education, access meaningful occupation, access to classrooms, dormitories, understanding that you have access to personal assistance services, Section 501 of the Rehabilitation Act of 1973. tee up your patients, make sure they have understanding and awareness that they have access. Improve access to workplace. California Assistive Technologies has a supplier directory now, and you can go in here and you can identify assistive technology for your workplace. It's a reasonable accommodation. We really have to advocate for our patients. And then of course, always asking for ergonomic assessments and options to work remotely. I spoke yesterday, we work with the California Department of Rehabilitation, which really helps seeking employment. And then I do want to touch on the adaptive driving, because our adults, they want to drive, and that's absolutely perfect. So, you know, how we guide them towards seeking guidance from the certified driving rehab specialist. I also run the driving program at Stanford. We have a driving simulator, but I only have mechanical hand controls, and most of my patients actually need electric adaptive driving controls. So here's the process. It is a long process to go through, but between all the right players and the right types of prescriptions and working with the right individuals, you can make driving a reality. This is an example of what electronic controls look like. So knowing that they have this distal strength, like that's where you place the electronic controls. And again, there are individuals who will facilitate this. Some are OTs, some are just certified driving instructors, but they will provide the guidance needed. And again, just another example of like, of what the controls look like for driving these beautiful power wheelchair vans, and that you would guide your patients to go to dealerships that know how to install this stuff. They really require the certification and to do the homework and get it installed properly. And that's just examples of dealers in California, not that important. And of course, my patients are still doing their activities of daily living, whether it's revising their utensils or using universal cuffs or adaptive plates or adaptive straws, you know, always just talking about assistive technology. And like I mentioned earlier, our patients don't come in that often. They're kind of done with rehab, but they come to the Neuromuscular multi-D clinic. And so I try and address their needs, like how could we work on your quality of living? And so that's where we connect them, with these independent living centers and vendors, and address all of their needs within, 2 times a year. So sorry to rush through, it was a lot to cover. Thank you for listening. I'm going to stop sharing my screen. And I have not been watching any questions come through, but maybe I could take a peek now.
Can you hear me?
I can.
Okay, so there were no questions popped up during it. Before I forget a second time, I just wanted to say I created under the communities tab where you can post a question. I put a thing there for wanting to start an OT community. So I've had, the wonderful experience of being part of this pediatric neuromuscular clinical research group and this international SMA consortium. And it's really been a wonderful experience. I've learned a wealth of information from working with other therapists who specialize in SMA. And I'm very excited and eager to see that we have a nice amount of OTs that are here today. And I think it would be great to really start a little OT network for several reasons. One, for referral purposes. So I see kids from all over the country. It's hard to know where to send them sometimes. But also I think as we talk about these, wonderful evaluative measures that we have, and SMA specific outcome measures we have, and then tomorrow you'll hear about, the transition to using typical developing and norm reference measures. There are some areas that are lacking in terms of evaluation, specifically for the non-sitter and some of the sitters. The distal hand function is a large area that I'd really like to dig into and look into. And I think the stronger network we can build and the more we can get people involved, whether it's clinical questions, referral resources, I think would be great. So if this is of interest to you, Kim and I have decided we're going to, build kind of an email distribution list. I spoke with Tina yesterday. It's my impression that this HOVA platform and app will live on following the meeting, and that we will still be able to communicate through that platform. So if that is the case, I think this would be a great way for us to share as therapists, share information. Again, this is not limited to OTs. The wonderful groups I referenced before where basically all PTs who let me in the door. So I had a few jokingly reach out and ask if the PTs were allowed. So I would love to have, PTs, physios, any other specialists that really have interest in upper limb function and rehabilitation for our kids and adults with SMA. So if that interests you, please just kind of respond with your contact information. And then Julie and I are happy to answer any questions that you have now.
I just wanted to thank you, Tim. That was fantastic. And I think that's a wonderful resource, for us to be able to reach out to one another. So I really greatly appreciate you and Kim spearheading that effort. I did want to mention one thing for my pediatric colleagues. It's just important to remind your patients, again, before they transition to the adult side, to constantly be mindful of their powered mobility status. It breaks my heart when I have some of my adults come to clinic and, they say, oh, it's been, 10, 15 years. I've been in the same chair. I've only swapped out my cushion twice, and I've only changed the tires once or twice. Like, I just really want all of us to continue to emphasize how important it is to, maintain the integrity of their posture and their cushions and their support, because that really is so important for their livelihood and for their reducing those risks of pressure ulcers and their safety and well-being.
So I see there was a question here, actually a very good question from Christine. Tim, for the patients you've gotten the recs for, what do you feel are the most important skills and functions that make them use the recs successfully? Recs successfully, that's a good one. And for long term. So I think the first thing that comes to my mind here is something Dr. Finkel said this morning. It's about managing expectations. So, and also about having your care being driven by patient and family, not necessarily always by what we think. Time after time, Kim and I have brought patients in with the recs. We capture range of motion, functional scores, everything without the recs first. We put the recs on. The child goes from 20 or 30 degrees of shoulder flexion to 140. They go from having to flex at the trunk and flex the neck down and support the arm and bring the hand up to mimic feed themselves, to they can freely and quickly as they want bring the arm up and down. And we see this immediate drastic improvement in function, or in simulated function, you could say. But they have zero interest in using it because they're still able to compensate. They're still able to do what they're capable of doing, and it's not really of interest to them at that time. So, it's something initially I used to push a lot and try to advocate for, but I find it's the wrong time because you want to get the buy-in of your patient and you want to get them long-term to listen to what you have to say. And ultimately it has to be their decision, the family's decision, and you have to go to meet their need. So in terms of, what the expectation is, if they're in managing it, if their expectation is that they're going to move freely and fully everywhere for every task, that might not be possible. But on the other end, I've had someone come in who we put it on, right? They have very little movement without it. We put it on. They can only flex the shoulder 10 or 15 degrees with it. They can only bend the elbow maybe 20 or 25 degrees against gravity with it. But it allows them, while they're operating their wheelchair, if their arm falls off the armrest, to get the arm back on to the joystick, or it allows them to take their arm from the joystick to their lap to pick up their phone, or now they can, instead of having to have their cell phone or their tablet in their lap and close to their body and kind of hyperflex their head down and have their workable space beat against their body, they can put their tablet upright or on the tabletop and they can reach away. So it's not always, the quantifiable improvement in range of motion or workspace that's the selling point. It's really what they're looking for, what they need it for. So again, it goes back to that patient interview and family interview and say, what are you looking to get from it? The easy part of the question asked, the single most important thing to people that makes them go for it is the ability to feed themselves. So I have tons of boys with Duchenne muscular dystrophy who have no interest in it. They go get a spinal fusion. Now they can't flex the trunk. They can't bend the hand. They can't use the body to get momentum to swing the arm up, and they can no longer feed themselves, and they come back for it. The challenges I talked about yesterday with the REX specifically, or it doesn't have to be the REX, any non-powered non-powered mobile arm support in SMA is that the triceps are much weaker than the biceps, and all of these devices aim to assist with elbow flexion. So the bands thereby are going to limit the amount of elbow extension they have. So sometimes you have to reroute the bands to assist with extension, allow them to flex. Sometimes you have to not use, if they're strong enough, you don't have to use those flexion joint bands. So it's tricky, but I think, in terms of the Rex or any other mobile arm support, you really want to be specific about what they're hoping to get from it. Make sure that they're able to do that, because you can set it either way. So, generally I set the Rex so that they can have as much reach and elevation of the arm as possible, but then still be able to get the arm back down to the joystick. But if I have someone that comes in that likes to paint, like our friend we showed in the video with the slings and springs, you can load up the bands so that his or her arm, right, floats freely in space, where they don't have to use their postural shoulder muscles to maintain the arm in space, and they can stay there for 20, 30 minutes and paint and be happy as can be. They might not be able to bring the arm down to drive the chair, but as long as they can bring it down enough, just to dip it in, in the paint or change colors, they're fine. So ultimately, it's what are they looking to get from it? Can you make that happen? And then letting them be part of the decision. The other aspect of the Rex is, looking at it away from function, but as a mode for exercise. So if we have kids that are on treatment, they're weak, they can't move a lot against gravity, the slings and springs or other support systems are kind of limited, and they position you there, and they allow for good movement, like at the elbow, this kind of marionette type thing, but they don't allow you for, diagonal reach or reaching straight up and down. So when you get a mobile arm support that allows more free movement, you're really giving more and more opportunities for muscle activation, for strengthening, for building endurance. So it can be used as a rehabilitative tool as well. I saw there was a couple questions on slides. Yes, the slides will be posted following the meeting.
So the slides are also available on the CME website using your login, and I've added instructions in the chat box for anyone who's interested. And if the slides are not there, then we will add them early next week.
Yeah, I have a lot of video that I'll probably have to remove just because it won't upload. So that's on.
And I added content after I submit them to the original CME. So maybe Dong, you could just let us know how to resubmit the new set, or I'll just send my new set to Mary and she can put them in.
Or you mean an updated set of PowerPoints?
Yeah.
Yeah, if you uploaded them yourself onto the CME website, whatever version you upload will override the previous one.
Oh, okay, great.
Yeah, so yeah, that makes it easier for you guys.
Oh yeah, that's perfect.
Or you can send it to Mary and she can do that for you too.
Okay, perfect, thanks.
Yeah, thank you.
I don't see any other questions coming through.
I don't either.
Well, guys, I'm smart enough to know I don't always make sense when I speak. There's got to be something I said during the talk that you want clarification on.
You both did a fantastic job. Thank you.
Thank you.
Thank you.
And yesterday there was a session that people could mill around in, but I don't know if that exists today.
No.
A session like the social hour, or
no, there was like a social hour, not for today.
Yes.
Okay,
yesterday, yeah, Tina kind of led that on yesterday. Just helping people to navigate the community, just as Tim created that that little group for the OTs, and so she kind of helped others who attended that session yesterday on how to network and how to find things. And like Tim said, that this the Huba app's going to be available even after the conference for you all the professionals to connect. Yeah,
so
Lizette
just posted an excellent question about determining frequency. So very good question. There's going to be several factors that contribute to this. The first and the one that's a hard stop potentially is what their insurance allows. So unfortunately, some patients will have 60 days per condition per lifetime type thing, where they view whatever you have as a broken ankle that you're going to rehab within 60 days and be okay. That's a horrific situation, but an unfortunate situation that does sometimes occur. Sometimes insurance companies will give X amount of visits per year or X amount of visits for an initial approval and then go from there. So from a, a frequency thing, there are things that are outside of our area of control. From a clinician standpoint, the way I view it is, it's not a straight win, right? There's risk reward and there's profit loss with every interaction. So if I'm going to ask the patient to come in for therapy and it's going to take them half an hour to 45 minutes to leave the house, they're going to have to get a sitter for the other children, or they're going to have to leave work early, pay for parking at the hospital, spend time with me, right? So it's not just an hour session that we see them for. This could be a 2-3 hour chunk of time out of their life. So the first thing is we want to make sure that we're providing a valuable resource. I'm a very biased source. I think I provide a very valuable resource, but I need to differentiate between, is this something that I can teach them in the clinic setting, right? Can I show them stretches? Can I take 10 minutes at the end of our clinic evaluation to show them stretches, give them a stretching program, talk about how they can, what types of toys or what type of play they can structure in the child's environment? Because there's often situations where, they don't need to come in for a hands-on OT. And this is going to depend on where they are in the course of their care. So if it's someone with a new diagnosis who's got a high level of impairment, that's someone you're going to want to bring in for outpatient therapy. And, you're going to want to see them once or twice a week, depending on what your goals are and how attainable the goals and what their knowledge is, so that you can really spend a lot of time educating and establishing their ability to carry out the things at home. Because ultimately, as a medical provider, my goal is that I'm going to train the family. They are going to be able to engage the child at home in activities that work to address their goals. They're going to be able to engage in the community in dance or music or sports or swimming, and they're going to be able to take leisure activities that are going to meet this need. And then as they change over time, or as their needs change over time, then I become valuable again, and then they come back in and see me, and I take some more sessions to go through. So, what we kind of do in our, well, not we kind of, we do in our SMA clinic setting is the patient comes in, we assess their needs, we see where they are, we determine what services they're getting in the community, whether they're getting school-based, early intervention, any outpatient-based, and kind of use that information along with the family's understanding and ability to implement these at home and make the decision from there. So I think on the high end, we've had kids, we've had some international patients and also some local patients have gene therapy and then do an inpatient rehabilitation stay. So on the highest frequency end, we have had kids come in for your standard live in the hospital, 2 times a day OT, 2 times a day PT, 2 times a day speech. We've had kids go and get day hospital where they come in at 8 in the morning, they check in, they have a whole day worth of therapy till 4 in the afternoon, they go home. Generally on the outpatient side, twice a week is usually the most we'll see these kids. After, generally after your initial, set of care, 10 to 12 visits, you should really be able to establish a pretty good program with the family that they can carry out. And now, the one positive thing that's come out of this awful pandemic is, the use of technology and telehealth. So this is a great opportunity for us as therapists that, the families rarely want to leave. They rarely want to discontinue therapy, right? They're worried about this break, right? Therapists always say, we're going to take a break. It terrifies the parents. So it gives you an opportunity to still maintain a relationship, schedule a virtual visit, actually see them in their natural environment, which has been something that's been very helpful for some of our patients versus in a clinic exam room, and to see how they function at home. And then the parent is the therapist, and you're kind of talking them through what to kind of do with them. So frequency, it's not a straight ahead answer. It will vary based on their need at that time and where they are in the disease process. And then also knowing, we know a lot more about this disease now. Historically, I really, outside of the ambulatory type 3 population, I really didn't see anybody for ongoing therapy beyond a few sessions just to kind of figure out what do they need from a technology standpoint, a positioning standpoint, et cetera. And then we would follow them in clinic. Now that these kids are changing, right? Now changing in a good way, I'm sorry. Now these kids are making improvements and gains. It's a much more frequent referral for actual hands-on services versus just consultative services.
Thanks, Tim.
I don't see anything else.
I don't see anything else. Well, it's
Anything else?
10:38.
All righty. We
The other
thank
thing,
you
just one
all.
last thing. The other thing I think is extremely valuable, and I always joke about, you have to start breaking up on the first date. So you'll want to think about when you meet the patient for the first time, whether it's in a clinic setting or they got the diagnosis or whether it's an outpatient visit, you really want to lay the groundwork for what the future is going to be, what our role is going to be, and and make them understand that, part of our job is to provide direct care. Part of our job is to educate them, and that, and then part of our job is to let them go for a little while to carry out this plan of care at home on their own. We're still there as a resource. They're going to come back again and follow up and see us in clinic again. And then we're constantly going to be reevaluating and changing this plan of care as it goes on. So just because, you're quote unquote breaking up or having this discontinuation of the active ongoing outpatient therapy, it doesn't mean that the therapy stops. Hopefully by that point, the therapy is going on in their home, in their community, with their activities, because we want these to be lifelong things that they're able to do. And the other thing I tell them is, I'm a lot of fun for a couple of weeks, but then I'm not as interesting anymore to the kids, and then they lose interest. So if they only come and see me for a couple of weeks and they come back 6 months later or a year later, I'm always a fun guy. They're always excited to see me. Therapy fatigue is real. They have other needs. The other thing I forgot to mention is you want to consider, are they getting PT? Are they getting speech therapy? Are they going in every 4 months for Spinraza? Are they in their loading dose? So there's lots of considerations that you have to take into place. And that's where, working with your interdisciplinary team and talking about what the priorities are for the patient at that time is really the best way to address that.
Okay, well, thanks everyone for coming.